Welcome, everybody. I am Dr. Ted Barnett, the president and founder of Rochester Lifestyle Medicine Institute, and I am so excited to be able to welcome everyone to this event, which is co-hosted with IHA and Rochester Lifestyle Medicine Institute, Lifestyle Medicine Grand Rounds. And tonight we will have an interesting case, reversal of hypertriglyceridemia and prediabetes, a case presentation. For those of you who are interested in presenting a case or being a panelist, you can reach us at grandrounds@rocklifemed.org. So tonight's agenda, we're launching right now with the announcements and introductions. At 7:35, we'll start the case presentation and panel discussion. And then at 8:15, we hope we'll be at that point, we'll be doing audience Q&A, so people can feel free to put questions into the chat and even raise their hand. This is not a webinar. This is actually a live Zoom meeting, so people can interact directly with us. And although we ask that you keep your microphones and your video muted for now. And then at 8:30, that's the official end, and you will then be receiving an email with a link to a survey. And when you complete the survey, 1 hour of free CME. And then we have a tradition of moving into the lobby. Oftentimes there's an active conversation going on. We don't like to cut people off. So that may go on for another 15 minutes or so. If you would like to partner with us to empower your patients, we have 3 ACLM certified programs that we run online and through Zoom meetings. And we run our own Jumpstart program, which we've developed. And then there's the LIFT project and PIVIU, which used to be known as the Complete Health Improvement Program. You can contact that name there if you'd like more information about that. Thanks to a generous donation, all of our CME courses are free to qualified medical professionals, and we have various programs worth between 10 and 24 CMEs. Dr. Kristi Artz is a diplomat of the American Board of Lifestyle Medicine and also an intensivist, practicing physician and leader within the growing field of lifestyle medicine, implemented food as medicine programs focusing on diet-related disease prevention and reversal within a large integrated health system, where she founded a medical specialty practice in lifestyle medicine. Dr. Artz is board certified in emergency medicine, an intensivist of the American Board of Lifestyle Medicine, and a certified culinary medicine specialist. Dr. Artz is the medical director of lifestyle medicine at Corewell Health, formerly Spectrum Health, and is the 2022 inaugural recipient of the American College of Lifestyle Medicine Special Recognition Award for advancing lifestyle medicine and health systems. So we're excited to have Dr. Artz. You'll see her in just a second. And I got to make this thing work. There we go. Dr. Greger probably doesn't need an introduction. Is a New York Times bestselling author and internationally recognized speaker on nutrition, food safety, and public health issues. He's a founding member and fellow of the American College of Lifestyle Medicine. Dr. Greger is a graduate of the Cornell University School of Agriculture and Tufts University School of Medicine, where I went to medical school. And in 2017, Dr. Greger was honored with the ACLM Lifestyle Medicine Trailblazer Award and became a diplomat of the American Board of Lifestyle Medicine. His books, How Not to Die, The How Not to Die Cookbook, and How Not to Diet became instant New York Times bestsellers. In 2011, Dr. Greger founded nutritionfacts.org, which I feel is one of the greatest sources of useful medical information, so I added that line. Our regular panelists, Dr. Brakey and Dr. Sunderman, I won't go into too much detail about them. Dr. Brakey is with IHA in Ann Arbor, Michigan. Dr. Sunderman was with IHA and is now with the Canyon Ranch in Lenox, Massachusetts. And both of their biographies are on our website under this event. And Dr. Susan Friedman is a board certified in geriatrics, internal medicine, and lifestyle medicine. She is my partner in crime at Rochester Lifestyle Medicine Institute. She loves to publish, and as you can see, she's the author of more than 40 high-impact papers, which have been cited over 2,000 times. And that's me. I won't go into detail about who I am. And let's have our panelists please go live.
Hello, hello.
Hello. Great. All right, thanks for joining us, esteemed panelists. And Dr. Artz, take it away, please.
Well, thank you, Dr. Barnett, Dr. Greger, Dr. Brakey, Dr. Sunderman. I'm so excited to be here tonight. And we do have a little special surprise toward the end of the presentation tonight. So with that, I will get started. And I thought I would first introduce all of you to our lifestyle medicine practice. I'm located in Grand Rapids, Michigan. at Corewell Health. And our lifestyle medicine practice is in a teaching kitchen space. So we're able to work hands-on in the teaching kitchen with our patients. And we have a private exam space you can see toward the back of the video, and then a classroom space that would be behind this image where we can run lots of different shared medical appointments, and where we can also do point of care testing on our patients. So we can track their progress as they move through lifestyle medicine interventions. And we are certainly aligned with the American College of Lifestyle Medicine, but we have simplified the pillars a little bit for our purposes, and we focus on nourish, encouraging our patients to eat whole plant foods, connect, of course, noting the importance of that social connection piece and group support, our move pillar and our restore pillar. So all of our treatments are focused on these pillars and using them as first line therapy for disease treatment, prevention, and reversal when possible. And I just wanted to give you a highlight of how we think about this in our integrated health system, that we're tracking metrics to really prove the value of lifestyle medicine. We all certainly are enthusiastic and support and individually, hopefully in our own lives, have seen the power of lifestyle medicine. But at a health system level, proving the case so that we can continue to scale and grow these programs is so important. And so this is what we're really thinking about day by day as we empower our patients to get healthier. And then lastly, just one quick last thing about our practice is the shared medical appointments. And I'll talk about several of those that our case presentation tonight that she had experienced as a patient in lifestyle medicine. And again, in this image, you see patients in our teaching kitchen space, working with our registered dietitian and cooking with whole plant foods, water saute methods, all of these things that we really encourage our patients to experience and learn and apply in their own lives. With that, I will launch into our case presentation. And so we have a 56-year-old female. She presented to establish care with a new primary care physician at Corewell Health. This was in early 2021. And her primary past medical history was focused on a history of hyperlipidemia and intolerance to statin therapy. She has several other past medical history conditions, some of which were being treated with pharmacotherapy. And the medications, as you see listed here, notably the Lovaza, she was on 4 grams daily when she had her initial visit with her new primary care physician. She was taking Acifex, had reported GERD symptoms that came and went, and something that was still troubling her. And then, of course, in her allergies, again, reported a statin intolerance. Most of this was muscle pain, muscle weakness when she had previously been on low to moderate dose statin therapy. And then her social history, as you see listed here, she's a non-smoker, previously had been in the military and had a rare alcohol consumption. Initial physical exam, she is pre-hypertensive and BMI just in the overweight range. And again, this is early 2021. Otherwise, a non-localizing exam, well appearing otherwise. Initial blood work was notable for a total cholesterol, as you see here, of 348. The LDL cholesterol elevated at 210 and triglycerides up in the range where they had been previously, and several of these lab values had been previously recorded at similar levels with her past primary care prior to coming to Corewell Health. And then, of course, the CK, now this was unique to this patient. It had been previously elevated, so it was drawn on her initial evaluation with her new primary care physician, and reference range at our lab at Corewell Health has a top normal at about 175. And she was noting some continued muscle aches that were ongoing at her initial visit. And given the results and her current treatment with high-dose fish oil and still having high triglycerides, her primary care physician had placed a referral to our preventive cardiologist to consider other treatments for her high LDL, high cholesterol levels overall, and considered whether she might need a PCSK9 inhibitor as part of her therapy. So on that initial visit, shortly after, this would be about March of 2021, similar history was obtained. She had no prior history of cardiovascular disease, nor had she had pancreatitis in the past. Reported the historically elevated CKs, even when she was not on statin therapy. So by problem list, what was discussed in this initial preventive cardiology visit, of course, the hypertriglyceridemia, and it was noted by the preventive cardiologist that this was likely a familial form, and was also noting that despite high-dose fish oil treatment, was still having elevated triglycerides on her serum labs. He did also note that dietary history had brought out that she had reported more carb intake, really enjoying some baked goods in the Grand Rapids area where she had recently moved. And then the elevated LDL and non-HDL cholesterol. At this point, given the history of statin intolerance, but quite elevated levels, the recommendation was made to restart statins. However, the patient was reluctant and declined at that time. And our preventive cardiologist then recommended a coronary CT to evaluate for any plaque disease and to make better determination of need for therapy. He did also recommend consideration for red yeast rice treatment, and that was considered by the patient, but not initiated. And then the elevated CK, again, he noted that this would not be a contraindication to restarting statin therapy. And notably, she had been deficient in vitamin D previously when she had experienced some of the statin-induced myopathy, and was currently vitamin D replete that had been tested in the lab and was taking regular supplements. And for those of you who don't live in Michigan, I think this past month, we've had a record 4 hours of daylight sunshine. So most people in Michigan are vitamin D deficient. But our patient was supplementing at that time, and as I mentioned, had acceptable levels. So Bob, if you don't mind starting our poll for our first question. So for statin intolerant patients, I'd like you to select your recommended therapeutic approach to reduce LDL. Now, I would say there might be more than one right answer, but this might be a good topic of conversation.
So what, Dr. Artz, what do you think? And then we're going to ask our panelists. So actually, let's start with our panelists. Dr. Brakey, what are your thoughts on this?
So, wow, first of all, great overview, Kristi. I guess one of my questions is, what was her diet when she came in? If it was already pretty good, then that really leans me towards familial. And if not, maybe she's just at that end of the curve from the standard American diet. I did a talk for PPOD called Plant-Based Normal. And if we look at the China study, the kind of Chinese folks on a whole food plant-based diet start at 88, average of 115, and have a total cholesterol of 150. And Americans start at 150, and of course, go up to 300 with an average of 215. So we're completely very little overlap. And maybe she's just on that end of the curve, and diet will help. But on this one, I choose the whole food plant-based diet. I think there are components of the portfolio diet like soy and soluble fiber that are helpful, but I'm not a fan of all of the components. So that's my question for Kristi and my thoughts on this answer.
Yeah. Dr. Sunderman.
I'm going to ditto Dr. Brakey with Dr. Artz. Thanks for sharing what incredible thing you have going at Corewell. I think we all dream about having that kind of facility to help our patients. So I'm glad to see that. So I agree with whole food plant-based completely. I think the dietary portfolio with the work that David Jenkins did is suggestive of that can be with the plant sterols can be very helpful. So I actually selected both. I think it's interesting too to see the preventive cardiologist, which true preventive cardiologists, I think of Caldwell Esselstyn, who rather than saying, oh, the fish oil didn't lower your triglycerides and improve your profile, that therefore it must be familial. And maybe you're just eating too many sweets and that's why what's going on. So we know that a true preventative cardiologist in the lifestyle medicine would really truly take a deeper dive into what this patient's dietary pattern really looks like. And we would have suggest whole food plant-based diet, maybe the dietary portfolio, instead of saying red yeast rice, because I think that's just commonly what's thrown out there. And as far as I'm concerned, I don't think I've seen the data to really support that to make a big difference.
Thank you, Dr. Sunderman. Dr. Greger.
So ironic to recommend red yeast rice instead of a statin. Doctors are skeptical about the ability of plant foods to treat disease, right? Our colleagues have no problem believing a drug like lovastatin can lower cholesterol, but red yeast rice? I mean, it's been used as a Chinese herbal medicine for over 1,000 years, but what did they know back in the Tang Dynasty in 800 AD? Well, guess what's in red yeast rice? Lovastatin, literally the exact drug. Instead of us synthesizing it in a lab, some purplish mold synthesizes it on rice and has forever. Now, the levels of the drug in moldy rice are way too variable to be reliable. So I certainly do not recommend anyone take red yeast rice supplements. But frankly, of course, I don't recommend most people take lovastatin either. I recommend eating healthy enough that you don't need either one. Whole food plant-based, throw in a little portfolio for me as well.
Sounds great. Dr. Artz, any comments before you continue?
Well, I think that worked out perfectly. I was hoping the red yeast rice would get Dr. Greger going, and it did. So excellent.
All right. Thank you for that, Dr. Greger.
And I'm thrilled to hear that our moderators have chosen the whole food plant-based diet. And I agree, the certain elements of the portfolio can be quite helpful for lowering total and LDL cholesterol, non-HDL cholesterol, and triglycerides. And I should add that our preventive cardiologist is very much a lifestyle-leaning practitioner. We are incredibly fortunate to have him on our Corewell Health team. And he does often prescribe whole food plant-based diet, even low fat, low oil for disease reversal reasons. So we're really fortunate. And in the records that I was able to access for this particular case, there was a reference only in terms of the dietary history that was taken at that initial visit, just around the simple carbs. That was really the comment. And then I'll share the next steps that occurred around referral to the preventive cardiology registered dietitian who the patient saw shortly afterwards. So I go ahead.
Dr. Artz, could you just explain to those in the audience what the dietary portfolio is?
Yeah, absolutely. And so Dr. Sunderman had mentioned David Jenkins, who had researched essentially certain dietary food groups that might be effective in treating and reducing particularly LDL cholesterol. So plant sterols, soluble things like tofu, soy milk, those would be included in the dietary portfolio. Soluble fiber from legumes, flaxseed, whole grains, of course, those would also be included in the dietary portfolio. Some of which I think what Dr. Brakey was mentioning around the elements around margarine, I've always had a problem with that one in the original study that's referenced. But I think when we focus on the plant sterols and the soluble fiber, we can certainly see a terrific impact by intentionally including those in the diet.
Excellent. Thank you.
Ted, if Dr. Greger could comment on Brazil nuts, are they still in your repertoire for reducing cholesterol?
There was that one remarkable, in fact, a little too incredible study showing that suggesting one single 4 Brazil nut dose was able to cause this dramatic LDL drop. There's been a meta-analysis more recently There's been only 4 randomized controlled trials that have looked at Brazil nuts. And 2 were on defatted Brazil nuts, which didn't seem to work, actually. It didn't seem to affect LDL, but the 2 that were on just regular Brazil nuts did indeed reduce LDL cholesterol. The only concern, of course, is exposure to too much selenium. Would not recommend eating more than a single Brazil nut a day on a regular basis.
Okay, so our initial medical nutrition therapy with the preventive cardiology registered dietitian. So our patient arrives with stated goals that she would very much like to reverse her high triglycerides and cholesterol through dietary change. She did report weight gain that had been relatively recent. Her kids came back from college. They were enjoying lots of, just celebratory foods, and she had had some weight gain. And then, of course, this visit showing the elevated serum labs that we have just been talking about. She had started already to make some dietary changes on her own, had recognized that that would be impactful, and then also had begun to implement some intermittent fasting. She had discovered our website at Lifestyle Medicine and started to pull down some recipes and begin to use those. So essentially the nutrition recommendations from that visit were putting her on a weight loss kind of track. That was a goal of the patient. And through that, mostly following a plant predominant dietary eating pattern. I think accessing a lot of the, again, recipes that we have available through Lifestyle Medicine, and just a very plant slanted diet, not exclusively whole food plant-based. And then starting to utilize some of the behavioral aspects around journaling, mindful eating principles to better manage her weight and food intake. Shortly after this visit, she was able to obtain the coronary CT that had been recommended, and results were reassuring. So there were no identified plaques. And through that, she had a score of 0, very low chance of atherosclerotic coronary artery disease. And if we had not had access to the diagnostic testing that she had obtained, we could use our risk calculator and estimate her ASCVD risk score. So with that, she had returned to see the preventive cardiologist, who was able to review these results with her. Repeat labs were done. This was about, I guess March to June. We have that there listed, and a really dramatic change after just a couple months of dietary change, essentially. So her total cholesterol, nearly in half, LDL cholesterol, similarly, as well as her triglycerides. So she's now in the normal range for her triglycerides. LDL is almost under 100 here. So she's made fantastic progress. She started to be more physically active, but has really begun to adopt this plant-based dietary pattern. So again, review of our problem list with that preventive cardiology visit. We're starting to wean off that fish oil. So we're going to go down to about 1 gram twice a day, with the goal to wean off completely if triglycerides remain normal and optimal. Similarly with the LDL and non-HDL cholesterol, that at this point, no additional treatment is required. We have that reassuring coronary CT results and labs looking remarkably better. And then the CK was not intentionally addressed at this particular visit. Okay, so audience question number 2 around, there is a science advisory from the American Heart Association on omega-3 fatty acids for management of hypertriglyceridemia. This was published in Circulation, August 2019. Each of the following intensive diet and lifestyle changes were specifically recommended in this advisory prior to the initiation of pharmacotherapy, except, so which one was not listed?
Dr. Greger, your comments, please.
Well, we've got a lot of work to do. Although certainly, all those other things are good things, and we would encourage them.
By the way,
But,
Dr. Artz, is that the right answer?
That is the correct answer.
Okay,
Yes.
thank you.
Yeah, so small changes beget small results. If we really want the full constellation of benefits, that would not only reduce triglycerides, but have a constellation of other effects, we should go all in and try to center our diets around whole plant foods.
Dr. Sunderman, any thoughts? So
Well,
really not
the
much to
good
say
news
about this.
The American Heart Association and American College of Cardiology now, with hypertension, they actually do mention that they recommend a plant-forward dietary pattern. So we're getting that in now. So fast forward from 2019 to 2022, we're making progress.
Right. Dr. Breakey.
Many of you know I've been doing this since 1977, and this is a perennial challenge where on my board exams in med school and on my AAFP recertification exams, I have to sometimes hold back on what I know is kind of the right answer and pick, now, what are the people testing this thinking is the right answer? And again, this is an example of where they're looking at some of the kind of outcome measures and missing, I think, as Dr. Greger implied, the forest, the fact that the big picture is how plant-based is your diet? What percent whole food plant-based? So it's a kind of a sad commentary on the agencies that make these recommendations, but as Melissa said, it's getting better, way better than when I started, but still a long ways to go.
Great, thank you for that. Dr. Artz.
Yeah, and I would say in the practice of lifestyle medicine and working with patients, it's always really, I think, easy in many ways to add great food to an individual's diet. A lot of these recommendations are about taking things away. Of course, we need to do that, but if we can lead with adding in these delicious whole plant foods, it makes the process of change much more acceptable to many people. So I also find it quite interesting that it's all about carbs, refined carbs, which of course we're all going to agree, limit or eliminate those from the diet, but can we bring in these health promoting foods alongside of that or even before that to really get people pointed in the right direction. So,
Right.
All right. Well, thank you, panel and everyone. So patient now arrives to our lifestyle medicine practice. She has referred herself. She is like all in now. She's learned about plant-based nutrition. She's begun to adopt a whole food plant-based diet. She really wants more. She's inspired. She's seeing the results and feeling the results. She does report a little bit of a sleep disturbance. This has been kind of long-standing, related to her military service. And interestingly, despite the improvements in her lipid profile, we are now seeing her enter into prediabetes range. So something, a little bit of insulin resistance is occurring, and something that we certainly want to address at this initial visit. So at our visits, we really focus on what are the goals, the health goals of the patient, and can we organize all of our recommendations around helping patients achieve these goals. So she selected those that you see listed here at the bottom, with the goal of trying to come off as many medications as she possibly could. So we measure in our 4 pillars of lifestyle medicine. So in our Nourish category, we utilize Diet ID for diet quality assessment. And she at this point had high diet quality, but measured in preferred style of flexitarian, but still very much centered on whole plant foods. She was using intermittent fasting several times a week. She was the primary cook in her family, so we always like to learn that. Who's cooking and shopping in the home? How can we engage them in the process of change? And then this little issue of loving baked goods. And I think that's what she would report in terms of the dietary challenges that she would point to. So our move category, she's doing some physical activity. We want to work on increasing that as much as we can with her. Close supportive family, so she's well connected. And then, as I mentioned, this sleep disruption that's been longstanding, but some of the environmental and sort of sleep hygiene tips that we could potentially provide. So the lifestyle prescription, again, with her health goals in mind and how far she's already come in her journey to improve, her health and her lipid values, we're going to begin by increasing, again, some of these high value foods, more plant proteins in the diet, really swapping out some of those animal proteins, adding in that ground flaxseed on a daily basis, focusing on our antioxidant rich foods. And again, very food focused recommendations. That's what we really prescribe in our practice. And then we wanted, since she was already implementing fasting in different ways, she was interested, particularly with the recent onset of the insulin resistance, to implement more prolonged fasting as well in her lifestyle regimen. We set some sleep goals with her, ensured she was supplementing with vitamin B12 at this point, given she was on a predominantly plant-based diet, and then reinforcing the ability of great nutrition to prevent cardiovascular disease and just pointing her to some excellent resources. And of course, How Not to Die, it's on our bookshelves. We got the cookbooks. Everybody sees a copy of that as well. This is a snapshot of our patient's journey over several months, and she was a highly engaged individual. And again, when we look at that process of change, I would say that is such a strong marker for patients being able to make and sustain change is how engaged they are in the process of learning the material, applying it to their own lives. And she really jumped into every shared medical appointment series that we offered over a series of months, including meeting up with our health coaches. We have what's called coach meetups. As you're all familiar, probably, we still are not reimbursed for health coaching, even though it's such a vital component to our patients' care. So we offer these every other week where our patients can drop in a group setting virtually and meet with our coaches to goal set, provide accountability, provide additional resources when necessary. She was engaging also in what we call our Fasting for Health series, and we were using the fasting mimicking diet in addition to whole food plant-based nutrition to really try to counteract the insulin resistance that had been discovered. So she was using the product Prolon, a plant-based fasting protocol, and doing this monthly for 3 to 4 months is what we had recommended. I wanted to highlight something that we also trend with all of our patients, and there's a little nuance to this because her initial visit, we have a body composition analysis, and there's one in the preventive cardiology space, and there's one in our lifestyle medicine space. We've never actually seen if they correlate exactly. And as I looked at these values, I wonder if there's a little discrepancy there. But if you can look at March 21, that was the initial cardiology visit. So we can see her BMI trending down nicely. We see her skeletal muscle mass, even with weight loss, has sustained. It did come down a bit, and we want to make sure as individuals are losing weight or using fasting that they're also maintaining their skeletal muscle mass through resistance exercise, particularly. But her percent body fat had come down. But again, I think there's a discrepancy that I'll have to uncover between our preventive cardiology space and our in-body. But it's a great way for patients who are very, data-driven to actually see the response that they're having in terms of their own body composition as we apply lifestyle as medicine. And just looking at a few more sort of snapshot lab values, we can see what I thought was quite interesting. So the elevated CK, rheumatology also did not have an etiology that they could definitively point to, but after a couple cycles of fasting, it came down into a normal range, which I found really interesting. Additionally, her hemoglobin A1C normalized. We'll see kind of final lab values in a few moments. And she was just doing exceptionally well with all of these changes, the accountability, the support. So we can see, again, different sort of view of the snapshot of lifestyle medicine care. So now we're in December of 2021. She is flourishing. And these are words, that really we were describing how she was feeling, how she was interacting with the staff, bringing the learnings to her own family as well. No joint or muscle pain, really feeling empowered about improving her own health. She had a follow-up with our lifestyle medicine registered dietitian in early 2022. She was able to come off Acifex and the fish oil, so we're now reducing and de-prescribing medications from her list. She's using plant-based recipes throughout the holidays, water saute method, so really applying what she's learning. And then finally, in April of 2022, she has normalized all of her values, her body composition, her lipid profile. She feels great. She is experiencing some menopausal symptoms, so we talk about the role of some plant phytoestrogens and just ensuring we're also using those in her dietary protocol. Okay, so this is just for my own curiosity, honestly. I'd love to learn from all of you, based on the evidence in your own clinical practice. How are you using fasting with your patients, particularly those with metabolic disease or insulin resistance?
Wow, this will be interesting. I can't wait to hear this. All right, audience. All right. Dr. Artz, was this what you were expecting to see?
I don't know what I expected, but I was just curious to learn from all of these colleagues on our meeting tonight. Yeah, we use it pretty routinely with patients, but certainly not everybody. But I would love to hear from Dr. Sunderman and Breaky also.
Sure. Yeah, let's hear from the regular panelists, and then we'll hear what Dr. Greger has to say. So
yeah, so I think that in 2019, Walter Longo actually spoke at ACLM, which was, wonderful. Because he's done great research on fasting mimicking and has the Prolon. So my question to you, Kristi, because just as far as accessibility, what is the cost, and can patients use flex spending accounts? I assume insurance doesn't cover this. What is the cost to the patient?
It's about $160, and some patients have successfully used flex and HSA. Yeah, to cover the cost. So it is a barrier still, but it's your food for the week sometimes too. But and when you look in the context, certainly of many of the medications that are prescribed, it's very cost effective. But
yeah, so obviously trends come, right? And so intermittent fasting, time restricted eating is a trend, but what the studies have supported is it does work. And what we do, we've seen with, like in this patient's case about the prediabetes, there's some good evidence to support that. What I found just on a practical note with patients is the mindfulness that kind of comes around with that, of having a window of, usually at about like 8 or 9 at night, I'm sitting down, relaxing in front of the TV, and before I know it, the bag of chips is gone. So I think just to bring some mindfulness around that, I think this has to fit, as lifestyle medicine physicians, we want sustainable behavioral change, right? So if this doesn't work, like for myself, I run every single morning, bright and early. I need to feel my body. So for me, a window starting at, noon doesn't work for me personally. But so I think as long as it works for patients sustainably, then that's great. And I have a lot of patients that really have had good success with this and have lost weight, have come off medications, have reversed some chronic diseases. So I think the evidence supports that. And in general, we do see caloric reduction with the intermittent fasting as well. So that's my input.
hey, Dr. Breaky.
I'm in the B camp. I definitely believe that 12 to 16 hours of rest time for your gut and your microbiome is healthy. Yeah, we've got to remember that we're feeding not only cells, but our microbiome. And if you fast for more than 24, 36, 48 hours, you're starving some of them out too. And they may start to eat their own mucosal layer or cannibalize each other. So I know there's a place for it, and especially, True North has got it down to a science. But I really believe that a big part of the success of these longer term fast programs, or even the Prolong, and I was at 2019 also, and appreciated Victor Longo's input, but I tend to, and I'm sorry, I'm not a big fan of the processed foods he puts out and the cost that comes with it. I prefer that Dr. Greger would say, nature beat him to the punch. Eat your vegetables. But back to my central thought there is that the average American only eats 11% whole food plant-based. So eating nothing is way better than an 89% painful diet. They do better when you remove all that processed and animal food. And so, but if someone's on the other end of the spectrum, eating a plant predominant or whole food plant-based, I don't think they need to go through many of the gyrations of prolonged fast. Yes, time-restricted eating, especially if they're trying to lose weight. But most of my patients, I encourage eat food to get to your proper weight and health goals, and then keep eating food.
Interesting. Thanks, Dr. Brakey. Dr.
good.
Greger. Dr. Greger.
I see some questions about Prolon in the comments. Basically, it's a 5-day meal plan, low in protein, sugar, calories, with 0 animal protein, 0 animal fat, in hopes of dropping the cancer-promoting growth hormone IGF-1 down. But as Dr. Brakey mentioned, what it is you know, you're paying, you know, $50 a day for a few dehydrated vegetable soup mixes, some herbal teas, kale chips, nut-based energy bars, an algae-based DHA supplement, and a multivitamin dusted with vegetable powder. Why spend $50 a day on a few processed snacks when you could instead get the same constellation with eating a few hundred calories a day of real vegetables, for example, if you wanted to, for 5 days a month. And in terms of time-restricted eating, that was one of the most fascinating things I looked into in my weight loss book, How Not to Diet, the chronobiology chapter. It's interesting. The time-restricted eating literature is all over the place. Why? Because there's disparate results between early time-restricted eating and late. And ideally, we want early time-restricted feeding. If anything, you skip supper, not breakfast. We want to push calories towards the beginning of the day. But when we do that, we do see metabolic benefit.
Great, thank you. And what your comment, Dr. Gray, your comments on the preferred title, should we be calling it intermittent fasting, or should we be calling it time-restricted eating?
So time-restricted eating, intermittent fasting, like every other day eating, has not been found to be preferable to daily, the same amount of daily caloric restriction may actually increase LDL cholesterol, and has not been found to be, higher compliance. There doesn't seem to be any benefit from the typical intermittent fasting, like alternate day fasting regimen.
Actually, well, thank you for that. I'm actually partly getting at the fact that I have a lot of patients kind of use those terms interchangeably. And it's not like, well, I'm a time restricted, they think intermittent fasting is restricting it during the day. So we try to get them to use the term time restricted eating. So, all right, back to you, Dr. Artz.
Yeah, and just my comments on how we apply fasting is that it is a tool that we have available. Dr. Brakey, to your point that, removing the dietary insult of the standard American diet is usually the best thing, and that may be the benefit. But I also agree with Dr. Sunderman that a lot of the behavioral aspects of why we eat, what our hunger cues are, it's been pretty interesting to see the process of applying fasting just so people can have insight and awareness to what they're actually doing on a daily basis. And I would say within an integrated health system, many of the patients are referred to us. They are not the motivated patient coming to Canyon Ranch that is ready and turned on to make changes. So we're oftentimes, working through sugar-sweetened beverages, fast food at many meals, and sometimes we need to break the cycle. And so I've seen benefit in that application as well, but 100% whole food plant-based, food is grown, that's where we want to go, but it is a tool that I think has a role in lifestyle medicine. So with that, just kind of overall, again, we're coming up to the end of this case presentation, and sorry if I've gone long, but this is sort of the vision of our health system and why I think lifestyle medicine really should be diffused across the health system, because we are simple, we're exceptional, we're affordable, and it is equitable care. And I think we can check the box in all these different ways when we apply lifestyle as medicine. And it's just really thrilling to me that we're able to do this in a large health system. And lastly, for our Dr. Barnett, if this is okay with you, we'll invite our lovely patient who has graciously joined us this evening to share maybe a couple minutes of her highlights with her journey in lifestyle medicine and what she's learned about her health and how she's improved her health. So
Please.
Nanette, I'd love to see you when you're ready.
Yeah, excuse me, Dr. Artz.
Yes.
It would probably be better if you could not be sharing, and
Yes,
since you only
I'll
got
do
it
that.
like one slide after, if you wanted to just cover that and then you could be out, or if you're just ready to
I
stop
will do
sharing
that.
now.
Yes, thank you. I just want to say a special shout out and thank you to my amazing coworker and colleague, Mariah Mundy, for her assistance in bringing this presentation together. She documents in all of our shared medical appointments. She's incredible. And she also is a tremendous support for patients like Nanette and others that we see in our practice. So I will unshare and would love to see Nanette.
Great. Thank you so much, Dr. Artz. That was fantastic. Loved it. Good job.
Thank you.
All right. And where is our, oh, there's Nanette. Okay. Dr. Artz, would you like to introduce? Yeah.
So, real quick. So Nanette, thank you so much for letting us share your story. We'd love to hear in your own words, just a little bit about your experience and how you're doing now and anything else you'd like to add. So thanks again in advance.
Well, thank you for having me, and for all the medical professionals that are here listening. I think the hardest thing for me was to find you guys. I knew I had high triglycerides and high cholesterol, and I wanted to not have any heart problems. I have a family history of that. All my siblings, my dad, my mom, all took heart medication. Also have Alzheimer's in my family, and then breast cancer. So anyway, lifestyle medicine. I actually found you guys through culinary medicine. I went to a cancer screening, and I just saw a beautiful flyer, on cooking Indian food, and it was an international cuisine, series that y'all were running through Zoom, and I was interested in learning how to cook, and that looked good to me. And you had a nutritionist with that, and that's when I really started to learn more about the nutrition and the importance of whole food, plant-based, and then at the end of one of the cooking classes, they went over that there was doctors and there was nurses that worked in lifestyle medicine. I'm like, wow, that's what I want. So I had went to my preventive cardiologist. He did talk about putting me on statins. He recommended that red yeast rice. Of course, I looked it up and I saw that it was something that was used and it had the word statin on it, and I wanted nothing to do with it. I had taken statins for years, and I also had a long history of different musculoskeletal, problems, tendinitises, plantar fasciitis, pitting, like edema in my lower legs. I'd been to so many specialists; they couldn't find anything wrong with me. So I didn't want to be put on statins again. When I was taken off of statins, in 2 weeks of being off of statins and just changing the way I ate, which was, I basically got off processed foods, decreased the sugar, decreased fats. I felt like $1 million off of statins. I had no idea that it was statins that was doing this. So I definitely didn't want to be put on those. He said he'd monitor me and he'd let me know. He had taken another lab test. My CPK was up, and nurse called me and said, hey, would like to have you consider be put on statins just once a week. I'm like, no. let's give me another month and then check my cholesterol and triglycerides and, and then can we go from there? I don't even want to consider statins. And so I stayed with you guys and, learning how to cook things that I love, but how to do it with less fat, less sugar, and Dr. Greger's 12, his it's not website,
His
it's
daily
an
dozen.
app. Yeah, that you can check to see what you're doing, what you're eating, and if you're not exactly why should I eat that? I can go to the app and there's explanations there, and if I want more, there's also a video on there. So it's very and I like to have like, how does this work for me? And so thank you, Dr. Greger, and that will continue to help me, I'm sure.
Nanette,
So anyway, yeah. So
I wanted to highlight one of the ways that you are sustaining and staying involved in the changes that you've made. And it's really lovely to see Nanette. She actually volunteers with our culinary medicine program now.
So I can say thank you to you guys. Yeah. And I'll have to say, like, I did the Prolon. It wasn't something that was really pushed. I was already doing intermittent fasting and I was getting good results with that. I was at a weight point that I could not break through. I was, I participated in a MOVE program through the VA, which was, exercise, counting calories, and just meeting, regularly. So I tried the Prolon fast, and for me, what it did was kind of showed me, hey, I'm not going to starve, or, I can make it through 5 days of giving up all the things that I love, like to kind of show me like, hey, you'll be fine. It's only 5 days. And during that 5 days, there is coaching with Prolon. You've got 100 people on there. They're all going through the same kind of thing. So that connection with them and them going through the same thing, like, oh, I was on the phone with my daughter. She stressed me out, and I grabbed for food right away as I'm, talking to my husband about, my daughter being crazy, and I'm throwing nuts in my mouth, and he's like, aren't you on that fast? So it really gives you an opportunity to, kind of share stories like that with other people, and to know that, hey, if you fell at that, that's okay. You tried, you tried your, you're trying to move along. You don't have to, we're so negative with ourselves, or so critical with our stumbles sometimes, and so to have a community to kind of go through those ups and downs with, I felt was very powerful for me. And, as the fast went on, some explanations from the dietitian that was heading everything up. It was just, it's like, well, this gives you an opportunity just to look at some of why do you eat? Why are you eating? Is it emotional eating? Like, yeah. So,
well, Nanette, thank you so much for sharing your story, and just, I'm so thrilled that you've been able to improve your health in so many different ways. And that you're also now sharing that experience when you volunteer in the classes and help others to improve their health as well. So thank you so much for joining us tonight. We appreciate it.
I appreciate it.
Yeah, thank you, Nanette, and thank you, Dr. Artz. And it's 8:28. This always happens. So thank you, Dr. Greger, Drs. Greger, Brakey, and Sunderman, and Dr. Artz again. I'm going to put up a slide, Bob. Just let me share for quickly, if I could. And here we go. So for once again, thanks to IHA for co-hosting this event, co-sponsoring this event. Dr. Brakey, we appreciate it very much. From Ann Arbor, Michigan. These are upcoming program dates and So these are the program start dates. I showed you there are some information sessions mentioned there. If you go to our website, it's very helpful to send patients, just say, go to their website and go to the free information sessions. We found that's very handy. I know Drs. Brakey and Sunderman have sent quite a few of their patients to our Jumpstart programs. They're some of our biggest fans. We have about 150 doctors around the country who have been referring to the Jumpstart. And so we're very grateful to them. And I'm going to stop sharing here. And I'm just going to say that, as promised, we're going to officially stop at 8:30, and everyone check your email inbox after that, and you should be receiving a message from us with a link to a quick survey. And once you complete the quick survey, you will receive your CME certificate. So for people who want to stick around for another 15 minutes, just 10 or 15 minutes, feel free. But class is now officially dismissed. Thank you, Dr. Greger, for your wisdom and for being our guest panelist tonight. Thank you, Dr. Brakey and Dr. Sunderman. We always love seeing you. And Dr. Artz, I really appreciate you did the hard work, the heavy lifting of actually putting the case together, and you actually lived it. So really, thank you all very much. And have a great night, everybody. And hope to see you next month at our next Lifestyle Medicine Grand Rounds.
Thank you.
Yep, thank you. All right. So that's the official dismissal. How many? We were at 8. We're still at. Oh, we still have about 60 people here. So Dr. Greger, you able to stick around a little bit longer? You're muted. So, but I'll take that as a yes.
Yes.
Okay, perfect. All right. Let's talk about some of the questions. Dr. Freeman, I know you're in the background there. Do you want to go live there? And were there any particular? Yeah, please.
Earlier on, there were some questions about monitoring of inflammatory labs and kind of what people do by way of practice, and what the rationale is for that. Things like I guess like CRP, but also lipoprotein little a and
right.
myeloperoxidase and things like that.
Yeah, Dr. Greger, any thoughts on that?
The one, well, I mean, that like the, the CT heart scanning, can help making those decisions when you're right in that middle on the 10-year risk assessment of whether or not to put people on statins. In this case, thank goodness she was statin intolerant. Otherwise, someone would have given her a script and sent her on her way. But statins wouldn't have helped her with her weight. Statins wouldn't have helped her triglycerides at meds. Statins wouldn't have helped her blood sugars. In fact, statins significantly increase the risk of developing type 2 diabetes, right? Statin users, to be expected, we expect 2 extra cases of diabetes for every 1,000 patient years. Of course, during that time, we would expect those statins to prevent about 6.5 cardiovascular events. But of course, it's a false dichotomy. We don't have to choose between heart disease and diabetes. We can treat both with the same diet and lifestyle changes. The same diet that can not only stop but reverse the progression of heart disease is the same one that can reverse type 2 diabetes into remission.
All right, thank you for that. Any of the panelists have any thoughts on that? Dr. Sunderman? Dr. Brakey, he's the first one to turn his camera, his microphone on. Go for it.
I was going to comment on that. I'm fascinated how someone can have a cholesterol of 348 and an LDL of 215 and have a 0 calcium score. And I would wonder if homocysteine, hsCRP, and ApoA are in a good range, sort of offsetting that very high cholesterol risk. Because I think we've all seen people with a cholesterol 100 points less than that and a calcium score of 120. It's like, how do some people not get the harmful effects of it? And obviously it's a combination of what kind of foods they're eating, their genetics, their environment, their sleep, their stress, and all of these play a role. We focus on diet as cholesterol, but these other components and microbiome dysbiosis also, we're all a community, and all of this kind of plays a role in that. But I think it'd be interesting, as Dr. Greger says, sort of whether to help see and understand why this happened. And I always certainly give the nutritional approach a chance. And sometimes, if someone's statin intolerant and they're still much too high, largely as a familial component, you may try, again, some of the dietary things we talked about, whether cinnamon, oats, Brazil nuts, soy, as additional dietary additives to that. And I don't know, occasionally even something like Zetia, which may be less harmful on the long term. And then I thought, sure, Dr. Greger was going to mention statins and Alzheimer's too. This lady has a family history of Alzheimer's. And when you just cripple one enzyme, you're not doing favors to everything else. So those are my thoughts, comments.
Yeah, so the original question actually was about the inflammatory markers. So Dr. Sunderman, could you please include that in your?
Oh, sure. Well, I was just going to add to Dr. Brakey, because when you have these sort of numbers that look kind of borderline high, scary, that someone would maybe be inclined to do a statin, but then had a Gaston score of 0. One of the things that can be beneficial is running an NMR profile, which the nucleomagnetic resonance, which really looks at a deeper dive into lipid, particularly the LDL, where we can look at particle size, and we can look at whether these are small, very dense with low antioxidants that tend to be more atherogenic, or are they larger, more buoyant LDL particles. So that can be really good information. And sometimes, if there are all these larger LDLs, maybe they're just not going to cause the atherosclerosis. In terms of the CRP, yes, with Ted's group, the Jumpstart, those are the biomarkers that we do trend. I think the CRP can be just really valuable information. As we know, it's very sensitive marker of inflammation, but not specific at all. It could be that, you've got a scrape on your leg versus you've got, cardiovascular disease that's ready to, implode and give you an MI or a bad cancer. But I think it is interesting to trend that as we do improve our gut microbiome, we know that 70% of our immune system resides in the gut microbiome. So as we do improve our gut microbiome with the prebiotics and our short chain fatty acids of all the fiber that we ingest, it's a good to trend that as well. I think like Dr. Artz was saying, like when you have a patient that can see objective data that's improving, right? Nanette was feeling better. She knew she was getting better. And then when you can also say, and look at your numbers too are getting better. I think it's good information to track that CRP as well.
That's helpful. I'm going to ask Dr. Artz in just a second, but as a radiologist, I just want to comment on the coronary artery scoring. It only measures the calcified plaque, right? It does not measure the soft plaque at all. You can have arteries that are very plugged up with soft plaque, and it's just not going to show up in a coronary artery scoring. So I'm always worried about that. I'm always concerned that we're going to be missing the soft plaques that are going to rupture suddenly and cause the MI. So, but those are just my thoughts. Dr. Artz, any comments on anti-inflammatory markers? Or inflammatory
the
markers?
only comment that I'll make is, to the lack of specificity of CRP. And it's just challenging, I think, for routine care to be following that marker, because if it's elevated, there's just a multitude of reasons that we could be considering. And particularly in, using lifestyle medicine therapy, particularly dietary change, I'm not going to adjust what my recommendation is, even if I see that. I mean, we're still going to be moving toward that whole food plant-based diet in a very strong fashion. So, and of course, stress reduction techniques. I know we've talked mostly about diet today, but I think an area that I am just so overwhelmed in a good way, I think it's just opening my awareness to the amount of sleep disruption in our patient population, and how much, that might even be raising the inflammatory markers that we're, measuring in our patients. And, addressing sleep often is the first thing that we need to do in order for someone to be able to make dietary changes in a sustainable fashion. So it's just multifactorial. And I think, again, we're going to be focused on the lifestyle behavioral changes. And predictably, we're going to see all of the labs improve, including inflammatory markers in most cases.
That's great. I appreciate that.
I just wanted to, if I can make one comment, Ted,
Sure,
I wanted to commend Nanette, because we're seeing her now, right? But she was the person that said when doctors, other doctors wanted to really push medication, okay, fine, just take it once a week. Just do it once a week. She, had the courage to say, no, this is not what I want. And then, had the courage to follow through and found you and your team, Dr. Artz, which is wonderful. And then I love all of the shared medical appointments that you offer, because so many of the times, we're the minority that we say eat plants, it's good, right? So many times we're the minority of, the average BMI, right? Of, 3/4 of Americans have a BMI of 25 and above. So that's normal, right? So to have the shared medical appointments is really helpful for not only education, but to have that group support and to have like-minded people that are supporting your journey. So I think that that's amazing that you have all of those different types of shared medical appointments that support the pillars of lifestyle medicine. But I just want to give a round of applause and a huge hug to Nanette for saying, I know there's a better way, and that we as lifestyle medicine practitioners are out there. And this brings me so much joy seeing Nanette reclaim her life, right? And get off medication and feel her best self. And the fact that she's talking about soy menopause, she's in her 50s. I can relate to that. So just cheers.
Yeah. Well, thank you for that, Dr. Sunderman. Nanette, I'm going to give you 30 seconds here. Do you have any comments on what you've learned about the healthcare system since you started this journey?
Well, I think it's more, having the courage to stand up and ask for what you want, and to be able to take your own health into your own hands. And if you don't get the answer you want from one, then go seek another. So I think more because I saw a preventive cardiologist, and that person didn't say anything about lifestyle medicine. I did tell him that I was going there and let me do this with my lifestyle changes. Yeah, so I think, and I would like to see every medical doctor say something in any plan of care to look at a whole food, plant-based diet and just dive in, whenever you can, if it's a class, if it's an article. But it's very helpful for Dr. Artz and actually my preventive cardiologist and one of my nutritionists in their plan of care, that we have access to now. They all have websites and everything, just for some patient education. Yeah.
Okay. All right.
Yeah.
Thank you for that. Yeah. Thank you. And congratulations again. Yeah. I appreciate that. Dr. Friedman, we have any other questions?
Well, there's a comment that sort of leads to a question, which is, I wish more hospital systems would embrace and financially support lifestyle medicine. It's sometimes a struggle being in medical education, trying to teach residents evidence-based medicine and also integrate lifestyle medicine without pushback. So my question is, Kristi, how did you manage to get this incredible center going? Do you have any sort of suggestions for people who are earlier in the process of how to help move systems forward?
Well, there's a lot there to unpack, but again, the short answer is that it's going to be an uphill battle. And I would still say we have not yet won. And, solving for the sustainability of a lifestyle medicine practice, I think should be project number one, top of the list for ACLM and our college to really support our efforts, because each clinician trying to, wage this battle within their own healthcare system, it's a really isolating thing to do. So the things that I learned is find your ally, build alliances across, whether it's within the delivery system, it may be in nutritional services. Where are those leaders that are like-minded who can share the support and the message, and then present. You have to get in front of every single audience that you can. So you have to say yes 100,000 times for years, until you've won enough supporters. And then it's the business. How do you create a business model that you can get your CFO to sign off on? And, you know, it has to be built on cost avoidance modeling. It cannot be built on revenue generation. So, you know, really looking to value contracts, ACOs is incredibly important. And then, you know, letting fee for service drive value transformation. So my example there, and it's something that we sort of scraped the surface at ACLM this year or last year, was, you know, find the pain points in the healthcare delivery system. And right now it's obesity, depression, and musculoskeletal disease. It's like the trifecta, and it's incredibly expensive. So if we can solve that problem within a healthcare system, we're, you know, we're making the case for lifestyle medicine to be there for the long run.
Oh, interesting. Thank you. That's and again, Dr. Artz, congratulations on winning that award, because that's what it was all about. Yeah.
Thank you.
Yeah. I'm going to see if Dr. Greger has any final words before we dismiss the class. Any final thoughts, Dr. Greger?
Well, you know, we've talked about, you know, lifestyle medicine is safer, cheaper, better. We talked about cheaper, we talked about better. Let me just say a few words about safer, right? Pharmacotherapy, 106,000 Americans dead every year, not overdoses, medication errors, illicit drugs, regular FDA-approved prescription drugs, 6th leading cause of death in the United States. Let's take something as seemingly benign as the acid blocking proton pump inhibitor Acifex, then the net was on. So safe now, over the counter, right? But FDA issued a safety alert over a decade ago that PPR associated with fracture of the hip, wrist, and spine. We have over studies, dozens of studies on more than 2 million people now, both short and long-term users at all dose levels, increased risk of hip fracture, as well as pneumonia, intestinal infections, kidney failure, stomach acid, cardiovascular disease, premature death. And the irony is most people taking these drugs shouldn't even be on them in the first place. PPR is FDA approved just for 10 days, rates by lowering 2 weeks for heartburn, 8 weeks for acid reflux, 2 to 6 months for ulcers, not for indigestion. 100 million prescriptions a year for this class of drugs, most of which for indications that don't exist. And it can be hard to stop the drugs. There's withdrawal symptoms. You put normal people on these drugs, then switch into placebo, and all of a sudden they start developing these acid-related symptoms. It is a boon for the pharmaceutical industry, but are doing much harm. And that's the safe over-the-counter drug. Don't get me started on all the rest.
All right. How about you talk about all the rest? Just kidding. Yeah. All right. Well, listen, it's 8:47. I want to thank everybody once again for coming tonight, especially our panelists and our presenter and our patient Nanette. And it was so great to see everybody tonight. Again, this is for medical professionals, and we hope to see you again next month. If you're not a medical professional, this will be available. Tell your friends, this will be available on YouTube. You'll all get a link. We'll send that to you in a couple of days, and see you next month. Take care, everybody. Bye-bye.
Thank you. Bye.
Bye.
Thanks, everyone.
Thank you.
Thanks,
Thank
Ted.
you. Thank you. Bye-bye.
Thank you.
Bye. Ted.
Thank you. Bye-bye.
Good to see you all. Bye-bye.
Bye.
No.
Bye.